Hey, welcome to the Healthcare Nation podcast. I'm your host, Rick Janata, and excited to bring you another episode, this time focusing on transformation within healthcare and the health sector specifically. We've got a tremendous guest, Dr. Wael Barsoum, and a little bit about Dr. Barsoum. He is a healthcare executive. He's a change agent. He's got over 20 years of experience in healthcare, both in the clinical setting as an orthopedic surgeon, but also in the C-suite. He's been the president and chief transformation officer at HOPCO, where he leads transformation efforts there, shifting from volume-based care to value-based care. Prior to joining HOPCO, he was the CEO and president of Cleveland Clinic, Florida. During his tenure, he took the organization from a single hospital to an integrated system with almost $2 billion worth of revenue. He has published over 200 peer-reviewed articles. He's a prolific presenter and appointed by the governor of Florida to serve as a member of the Florida Board of Medicine. Looking forward to a great conversation with Dr. Barsoum. And with that, Dr. Wael Barsoum.
Sure, I'm happy to. And Rick, thanks very much for having me. It's a real pleasure and an honor to be here with you. So I do have an interesting journey. After finishing medical school at Ohio State, I went to do my residency at the Cleveland Clinic. And I had an incredible time there as a resident. Following that, I did my fellowship at New England Baptist Hospital, which was a little hospital in Boston that does a huge number of total joint replacements. So I learned how to be a really good, hip and knee replacement surgeon, and then came back and joined the Cleveland Clinic afterwards. And while I was there, our chief of staff, who's a wonderful guy named Joe Hahn, kind of picked me out to participate in some of the leadership training programs that the Cleveland Clinic had. And that's one thing that I think was very unique about the organization is Toby Cosgrove, who became the CEO there, probably about 3 or 4 years into my time as a staff doctor, had identified the fact that we didn't really do a great job of training our future administrative physician leaders. And as you know, the Cleveland Clinic is very high on physician leadership. But most of us, obviously, in medical school and residency, don't really learn any of those types of things in healthcare. You may in college if you're president of your class or on the student government, but you certainly don't get the opportunity to learn a lot about healthcare administration. So they put together this program and identified me as potentially somebody that should participate. So kind of going through that, the deal was if you do the program, it's kind of expected that you pay the organization back and you play some kind of a role. So my first role as a leader there was as vice chairman for operations for our department, for the Department of Orthopedic Surgery. And some of the things that we focused on were reducing length of stay, getting patients out of the recovery room more quickly, discharging folks in a safer manner, reducing complications. So all these things that as it turns out, and I'm sure we'll talk about this later, clearly show the tie-in between high reliability organizations and operational mastery and value and quality. It clearly became obvious to me that these things are very, very intertwined. And I think many industries discovered that a long time ago. Healthcare has still been, in many ways, delivered as an art and less as a science. And bringing operations together with healthcare really made me see the value of bringing science into our healthcare processes more consistently. So after serving as the vice chair of orthopedics, I then became the chairman of surgical operations, which oversaw about $1 billion of the organization's revenue, and that was all of surgery across our footprint. So all of our operating rooms in Florida, eventually in Abu Dhabi, in Cleveland, of course. So we had about 200 operating rooms that we oversaw, several ambulatory surgery centers, and we managed everything there, whether it was supply chain, quality indicators, managing people, including nurses and surgeons while they were in the operating room, scrub techs, all of those things together. And then kind of the surprise of my life, which turned out to be one of the greatest things ever, was when I was asked to come down to Florida to be the CEO of Cleveland Clinic, Florida. And again, kind of more on the job learning, and applying much of what I had learned at the Cleveland Clinic and through some of the programs that they sent me to, including, Kellogg had a leadership training program, Harvard School for Public Health, Harvard School of Business, all had healthcare leadership programs that I was able to attend through my time at the Cleveland Clinic, and they were all, extraordinarily helpful to kind of allowing me to do what I'm doing today.
I have to just comment on that because I remember early in my career, I was a rare, persona because I had a clinical background as a nurse and nurse practitioner. I also had an MBA and I was in leadership positions. And candidly, there wasn't a lot of docs. There wasn't a lot of physicians in that space. But I saw that change rapidly over the years. And I applaud the clinic. It's always been a hub of innovation across the board. And Dr. Cosgrove, who you called out specifically, to recognize high talent and to put the investment behind that, to really take the individual who's capable and really has a desire to make a difference in a position where they can give back in a very different way, not marginalizing anything clinically, but obviously the impact factor is different. So that's tremendous. Now you made the transition from, I would say this, from the surgical side to the executive side. Any pearls of wisdom when you think about what you did, taking care of a patient, let's just say one at a time, to leading a billion dollar organization?
Sure. So, the first thing I would tell you is I've always remained clinically active, and I still actually am clinically active. I still do hip and knee replacements. I think it's helpful to be able to kind of walk in the shoes of everyone that's at the hospital, all the folks trying to do their best to take care of patients and to understand the challenges at that level. So that transition has not been kind of a sharp demarcation. It's been more of kind of a gray zone, almost a watershed, right? Going from fully clinical to a little bit of administration, a little bit more administration. And again, I would say that kind of being able to be clinically active has allowed me, at least I hope, to be a better administrative leader in healthcare. One thing as a clinician that would always frustrate me, and I'm sure, when you think back, to your clinical time, was when a patient would tell you about some place that we failed the patient in their care journey. I would take that very personally, and I would follow up on that. Every complaint that I ever got from a patient, even before I held any administrative role, I would follow up on it, and I would try to understand, why did this happen, and why can we not do this better? So many of the things that I wanted to really push on were felt to be kind of out of the box, right? I mean, when I first started doing hip and knee replacements, patients stayed in the hospital routinely for 3 days, and probably 80% of the patients would go to a rehab center afterwards. And it never really made a lot of sense to me. So putting together predictive models around research to reduce that length of stay, and then applying that from an operational perspective to reduce length of stay and improve how patients were discharged to make sure that they were safe when they went home, was a real game changer. Now we talk about outpatient total joint replacement and what a big change that is. The amazing thing is at the Cleveland Clinic, we were reducing our length of stay for total joint replacements starting about 17 or 18 years ago. In fact, I did my first outpatient total hip replacement about 12 years ago. And that, has only recently been catching on.
Yeah, that is amazing. Listen, the thread in that, I think, is transformation. And that brings me to your present role as President and Chief Transformation Officer at Hopco. Tell us about that. What do you do? Well, tell us a little bit about Hopco and also what your role is there, what you're charged with. And obviously, I'm interested in the transformation component.
Sure. No, happy to. So Hopco stands for Healthcare Outcomes Performance Company. And it's a wonderful company that was founded by actually a very good friend of mine who was also an orthopedic surgeon. He was at the Mayo Clinic about 18 years ago when I was at the Cleveland Clinic. And I remember him calling me, telling me, listen, I've got this idea. I'm going to leave the Mayo Clinic and I'm going to move to Arizona because this is one of the 3 best markets to do what I want to do. I'm going to start a practice. I'm going to partner with hospitals. I'm going to take risk from insurance companies. Why don't you come with me? And I said, David, I have no idea what you're talking about. Are you crazy? you're, a world famous guy at the Mayo Clinic. I'm, at the Cleveland Clinic. We're at the pinnacles of our career. Why would we do this? He said, no, you'll see. One day you'll see. And he was right. So, he had this incredible vision, candidly, a vision that was probably ahead of his time in many ways. And 2.5 years ago, I joined it. So what we do at Healthcare Outcomes Performance Company, HOPCO, is kind of three verticals. The first vertical is manage musculoskeletal practices. And everything we do focuses on musculoskeletal care. So it doesn't just mean orthopedic surgery. Anyone that touches the musculoskeletal program, we work with. So pain management doctors, chiropractors, podiatrists, neurosurgeons that do spine surgery, primary care providers who in many cases might see 30% of their volume might be touching the musculoskeletal system. So we'll work with all of those different providers. So we manage practices and we'll provide a lot of the back office work, but we'll also give them the tools to be more scientifically driven and be kind of higher value providers. And when I talk about value, I use kind of Michael Porter's value equation, quality over cost. So how do you improve quality and how do you decrease cost? Our second vertical is working with healthcare systems, where we'll work with them on managing their musculoskeletal service line. And this includes everything: supply chain, bringing costs down, while maintaining the quality of the products that we're using, marketing, operational excellence in their operating rooms, partnering with clinicians so that you don't have a winner and a loser when a doctor comes to a hospital and they're working on a project together. Everybody ought to win, most importantly, the patient. And then finally, working with payers, with insurance companies, where we will actually build clinically integrated networks that take risk for musculoskeletal care. In some cases, that may be, a bundled risk for, surgical bundles. It may be condition-based bundles like osteoarthritis or back pain, all the way up to taking full risk on all 26,000 ICD-10 codes that touch the musculoskeletal space. So that's what HOPCO does. We're now in 33 states. We're the largest, by far, actually, the largest musculoskeletal value-based care company in the country. We have a digital platform that is partnered with the NHS in England and in Australia, where we have the ability to work with patients remotely in terms of physical therapy and remote therapeutic monitoring, kind of trying to push clinical care pathways to ensure that patients are getting the right care the first time by the right provider at the right site. And all of these things are kind of tied together to ensuring the most value-driven healthcare solutions that we can.
So, Will, I've got two comments on that. One is, and I would send this out to any aspiring healthcare leader. What you described is a universe of possibilities outside the four walls of a hospital, certainly for aspiring executives, which I think is so absolutely cool, forward thinking. And I also believe probably is representative of what kind of healthcare system we're going to have in the future. And that brings me to my next question, which really is, what are the new competencies for healthcare executives? I think there was a lot in that response you just said, and I think there were a lot of those, absolute requisite capabilities you'd need. But in general, tell me about the core competencies that you're going to need to be a successful healthcare executive moving forward.
So I think it's a few things. I think, first and foremost, you have to make sure that you put the patient experience first and foremost in your mind. And look, I fully recognize that we can't necessarily make sure that every patient has the outcome that they wanted. Okay. Meaning, and I say this sadly, right? I mean, if you have a grade 4 glioblastoma, the chances are it's going to be very difficult for you to live 20 or 30 years beyond that. But what we can do is we can make sure that we provide you with the right care at the right time. We are sensitive to how news is delivered to you. We can try to make your experience and the experience of your family members as positive as possible throughout the process. And we can give you the right advice to ensure that you get the most appropriate care that you need at that time. So I think that's a competency, is understanding how to see things through the patient's perspective, right? Not every patient is going to come in and get a straightforward total hip replacement, go home the same day, and be skipping down the street 6 weeks later. But it doesn't mean that we don't owe every patient the effort to ensure that their care and that their experience is as positive as it can possibly be. Frequently, one of the challenges that we have when we talk about competencies is we judge competencies based on, KPIs, key performance indicators, that may not be terribly meaningful to the patient, right? We look at them from our perspective because it's been dictated to us that these are the most important KPIs. But when you start looking at it from the perspective of a patient, they may not be the most important performance indicators. So looking at it from their perspective, that's number one. Number two, I think, the clear operating metrics to ensure that you're doing a good job running whatever you're running, whether it's an outpatient dialysis center, whether it's a LTAC, whether it's an ASC, whether it's an acute care hospital, whatever it is, you clearly need the core competencies to understand how do you run it well and how do you run it efficiently. The third is understanding, new technologies as they enter healthcare. How do we embrace them? How do we customize them to work well? I mean, imagine if every time you were going to get on an airplane, Rick, you have to go to United Airlines or the Delta Airlines, ticket booth, stand in a line, buy a paper ticket, make your reservation, leave, and then keep track of the ticket. Now obviously you can't change the seat you've been assigned. You can't refund your ticket without going back. It doesn't work anymore, right? We have to evolve in healthcare just as industries have evolved around us. And I think, candidly, we've been slow to do that. We need to get better at it. And then finally, understanding this very real risk, shouldn't say risk, but very real opportunity, which most people still see as a risk, of moving from volume-based care to value-based care. And I will tell you, I've heard countless healthcare executives talk about how they have to do this, how we have to do this. But very, very few actually have the competency to do it, and fewer than them are those that have actually started the process, because it really is a risk, right? I mean, when you're good at providing volume-based care, it's scary to start shifting that into value-based care.
That is such a good point. I will say this from my personal experience. In the last few years in the institutions that I worked in the C-suite, I was looking more and more at risk. And the other thing, with very tight capital, you expected, in fact, vendors and companies, and as you work with payers, we would see commensurate risk on both sides. So with that said, tell me and give us some definitions so we could kind of level set with the audience here. Volume-based, value-based, and unpack that for me, Will.
Sure. So volume-based care is what, all of us have historically experienced, right? You go to the doctor, you pay your deductible, your out-of-pocket payment, the doctor, the nurse practitioner, the PA, whoever you saw, the physical therapist, sends a bill to your insurer, the insurer pays that bill. Traditional volume-based care. It's just like going to the supermarket. If you go to the supermarket more often and buy more things, you're going to have a higher bill. Same exact thing, right? Value-based care really is more around incentivizing wellness. How do you make sure that a patient gets the very greatest service for the money spent on that service? So instead of being incentivized to take care of sick patients more and more often, you're actually incentivized to keep patients as healthy as possible. So good examples of that are what we're starting to see more and more in managed care organizations, like some of the organizations here that we see in South Florida that take full risk for a Medicare Advantage population. Those patients come and see their primary care provider, who, again, may see them more often, but isn't getting paid for each one of those visits, is instead taking this pool of money that has been set aside from the federal government through the Medicare Advantage plan, and they're incentivized to keep them as healthy as possible. And when they do that, the physician is incentivized, the patient is incentivized, and society is incentivized, because there's been a very real financial savings in the care of that patient. So good examples of that would be, looking at something like like breast cancer, right? If a patient sees their provider more often for preventative visits, the likelihood of picking up a breast lump is probably significantly higher than if instead you just see the doctor once a year or once every 2 years for your visit, at which point the lump may be, twice or three times the size, may have already started to spread, it may be intraductal, and then the cost of caring for that is significantly higher. So I think the best way to think about it is being incentivized to keep the patient from getting sick to begin with.
Great points in that. And I can't help but follow up on your comment about Medicare Advantage. I personally believe that there's probably going to be a push politically, policy-wise, when you look at solvency of Medicare, to go for a more managed Medicare component. What are your thoughts on that? And also in that, throw in bundles. I think that bundled care with respect to, say, joint replacement.
Sure. So I'll take the first part of your question first. CMS, the Center for Medicare and Medicaid Services, has been very clear about their desire to push more and more providers, more and more patients into risk-based solutions. So Medicare Advantage, without a doubt, will grow. I think it probably needs some fine-tuning in terms of how it works today, but it does. But I'm quite sure that it will continue to grow. And again, I mean, the federal government is by far the largest payer for healthcare services in the United States, so they have the biggest muscle, and they've made it very clear that they want to grow that. Now, they work obviously with private insurers, United Healthcare. Here in Florida Blue is one of the big providers. Another one is Humana. So they do work with the private insurers, and I do think that it will probably take more what I would call public-private partnerships to kind of get the Medicare Advantage plan to where we really want it to be, because there is still some gaming of that system, right? The reality of it is the amount of money that gets provided to the managed care provider is directly related to how sick the patient is. So some folks have kind of figured out, well, if I document more and more and more, I get a bigger check, and then if I don't spend that money, I can make more money. So there probably needs to be a little more checks and balances. And again, I would say that this is an opportunity for us to do a better job with a program that is really designed to benefit both the providers and the payers, and then, of course, most of all, society. So I don't say that in a negative way. I just say it as an opportunity to make things better. As far as bundles go, the whole idea of bundles was to take cost out of the healthcare system, and I think it's been fairly successful when you look at many surgical fields. So hip and knee replacement is a great example of that, where we saw the utilization of post-acute care drop dramatically when bundles came into place. So a surgical bundle, to kind of define it, would have some period of time before surgery and after surgery where there's a set pool of money that is utilized for taking care of that patient. So for a total hip replacement, it might start 7 days before the surgery. It might end 90 days after the surgery. And any complication or any care provided to the patient throughout that period of time is paid for throughout that surgical bundle. Now, historically, what would normally happen is every year, the bundle target price resets and the price goes down. As that price goes down, as we've taken more and more cost out of the system, that should leave a larger and larger pool of money that stays, at the federal government level or in the commercial level, if you're working with a commercial payer, that can then be utilized to provide healthcare services elsewhere or to expand some of the insurance benefits for the plan or to reduce the cost of the insurance plan. So all of those things. The challenge for clinicians is they kind of saw these great savings early on, but after they've squeezed a lot of the cost out, there aren't any savings moving forward. So many times they'll opt out of the program. They don't want to continue to be in the bundle program because there's no more savings to be garnered. So again, I would say that this is an opportunity for us to think about how do we create programs that do take out costs, that do improve quality, but equally importantly, are sustainable. They're programs that we get engaged in, that we consistently improve on, and we want them to be sustained because they've benefited everybody that's been part of this cycle of patient care.
So let me take a little pivot from those comments, which are so spot on and really important, and think about models of care, new models of care, and maybe more specifically, the consumer entrance. I will call it that, the retail model. So I'm thinking about Walmart, thinking about CVS, their recent purchase of Oak Street, the big primary care group, Amazon, and their purchase of One Medical. Seems like they're all getting into healthcare, and it's very accessible. It's a transactional model that perhaps some millennials and Gen Xers, could relate to. What are your thoughts on that?
Yeah, look, the reality of it is, when it comes to healthcare, one of the keys that we have to always be focused on is access, right? Ease of use. Okay, why do almost all of us have an Amazon Prime membership? Mm-hmm. Because it's amazingly easy to jump on the app, order what you want, and have it delivered to your home. In many cases, the same day, if not the next day, right? It's easy. So we like that. Same reason we use our airline apps to buy our tickets, to download our boarding passes, because it's easy. This is, I would say, something that in healthcare, hospitals have not been very successful at. We have not made it easy to get our healthcare. In the United States today, the average length of time that it takes to get an appointment, a new appointment with a new provider for primary care, is about 36 days, right? That doesn't work. If a patient needs to see their doctor, their nurse practitioner, their PA, waiting over 30 days for that first appointment is illogical. So it only makes sense that groups like Amazon, CVS, Walmart are going to get more into the business, because they happen to already be very good at the delivery side of it. They're just not very good at the healthcare side of it. So they've got to, just as we're getting better at the delivery side, but we're good at the healthcare side. So one would think that the ideal scenario is actually starting to put healthcare systems in partnership with some of these delivery arms. And I think we're going to see more and more of that happening. I would also say that there are examples of scenarios that have not gone so well. So you probably remember the big private equity company that got involved in healthcare. That was
the J.P.
Warren Buffett's company.
Yeah, yes, and
J.P. Morgan, Berkshire Hathaway, they all got together, right?
Atul Gawande, yep.
Completely failed, right? Why? Because they were great at one thing, but not so great at the delivery of healthcare, right? There were no operators from the healthcare side that were really involved there. So that just didn't do very well. And I think that's the real challenge. Healthcare is difficult. It's not easy to get this right. And it's highly, highly regulated. So making sure that we can continue to provide that high quality care, but make it easier to provide it, that I think is a very real opportunity for us. So I personally welcome the Amazons and the CVSs and the One Clinics all kind of coming together and providing this, because I think it's the right thing to do for our patients and the right thing to do for our society.
So, Will, I think I could say we both grew up in hospitals. We cut our teeth there and have seen the evolution and change that's happening, some obviously in the consumer space that you just mentioned. What is the future of hospitals, the notion of a hospital? I mean, is it going to continue? I mean, where is it going? What will the hospital look like in 10, 20, 50 years?
Yeah. So the first thing I would say is we probably have too many hospitals in the United States. And if you look at the data today, it's pretty clear that we're overbedded by about 40% across the country. So some hospitals are going to close. And, these are probably the older, large acute care hospitals that are now running at 50 and 60% capacity. And you've got another newer hospital 2 or 3 miles down the road. I think the notion of every neighborhood needing a hospital is going to go away. And rightfully so. I mean, hospitals are very capital intensive. They are human capital intensive as well. It costs a lot of money to own, run, and manage a hospital. So I think we need to right-size the number of hospital beds that we have. That's number one. Number two, the idea that we might, in our lifetimes, see a scenario where we have no hospitals is not realistic, right? I mean, there are always going to be patients that need emergency departments connected to hospitals for intensive care and critical care. That's not something that we're going to solve over the course of the next 20, 30, or 40 years. I do think more and more care will be provided in the comfort of most patients' homes. Patient-centered homes, whether surgical or medical homes, are becoming more and more popular. Kind of the lower acuity care that was provided by hospitals, I think is going to shift to lower cost of service sites, including the home. But I think that hospitals will, so I do think kind of in the end, hospitals will end up being a lower number of them, but those that do exist are probably focused on higher acuity care, and will be, appropriate for the care that they're providing. So that's where I do see this all going.
Yeah, great response. Really, again, I think you're touching on such key points that are going to be long lasting and influence the perspectives of a lot of leaders and policymakers who are out there right now. I like to always wrap up the episodes on a positive note, and I want to ask you, what are you most excited about, optimistic about, looking forward to with respect to healthcare delivery, the sector, everything that's rolled up in it?
Yeah. I'm a very data organized person, right? I mean, the way that's just kind of how my brain works. And I like metrics, and I like seeing metrics move and things change. I mean, that's really why I became an orthopedic surgeon. I love the idea that a patient comes in with a problem. It's evident on an x-ray. I can fix it. I can look at an x-ray later and I can say, well, this worked out well. I fixed that problem, and here's proof that I fixed that problem. I'm excited to see how we transition. Over the course, I think, of the next 10 to 15 years is going to be a real luminary time for us in healthcare as we see new technologies becoming more and more integrated into healthcare, whether it's artificial intelligence, whether it's virtual reality, whether it's predictive modeling. All of these things that are helping to drive change in healthcare at a meteoric speed, I think, is very, very exciting to see. And we're going to have very real metrics that we can measure, right? Have we reduced that amount of time that it takes for a patient to get a new appointment with a primary care provider? Have we meaningfully reduced the cost for providing a primary total hip replacement to a patient that has end-stage osteoarthritis? Have we reduced the complications? Have we reduced readmissions? Are we able to provide physical therapy now consistently, remotely, on a Zoom screen or some other type of methodology that allows a patient to not take a half day off work to go and see their therapist? All of these things are really exciting to me. What are we going to see happen with our DNA, right? Today, just with a buccal swab, right? You just take a swab, put a little saliva on it, send it off to the lab. You can get pretty incredible information about what are your risk factors when it comes to heart disease, diabetes, cancer, right? How are we going to start using that information now in a meaningful way to help reduce some of the human suffering that we see all around us? The next 10 to 15 years are going to be very exciting, and I'm excited to see that happen. I'm excited to measure the results that we see from that.
Fantastic. And on that note, Dr. Wael Barsoum, thank you for sharing your time, your thoughts, your expertise, and the incredible career you have, and you're continuing to have, the impact factor you're making, particularly with respect to transformation. It's been great having you. Great conversation, Wael.
Thank you, Rick. It's really been a pleasure, and I look forward to following your podcast. Thank you.